Welcome to EMDR Chat with Curt and Michelle. I'm Dr. Curtis Rounson.
And I'm Dr. Michelle Gottlieb. That seemed a little difficult for you to say this morning.
Yes, it is. It's a little difficult to say.
But we're glad you're all here, even if we're not sure who or what we are.
Right. It's hard to say EMDR. There's the letters. They're confusing.
Yeah, it's a challenge.
I love the patient that comes in and says, I want to do that ERMD thing.
Yeah, exactly. Right? That EM what? Yeah, exactly. Hey, Curt, what do you want to talk about today?
That's good. I really don't know, Michelle. It's kind of one of those things where I'm thinking, we don't have anything to talk. Wait. I do.
Wait, you got something? What you got?
What's interesting to me is, for some reason, over the last few years, since I've done EMDR and have worked with a lot of complex PTSD clients, how many of them have come in and they've been given diagnoses from the DSM that, like, bipolar disorder, acute psychotic disorder, all sorts of the big old diagnoses from the DSM-5. And when you actually get into it and you begin working and doing EMDR on their trauma, you find out, that's why my mood stabilizers did not work, because I'm not bipolar. Or, you mean I'm not psychotic? No, you were having a flashback phenomena.
Right.
And the number of times that's happened has increased a lot in the last few years. Now, in our trainings, one of the things we talk about to our participants is that we hope by the end of the third weekend that they're able to look at the DSM, our Diagnostic and Statistical Manual, and realize that what it is I'm going to say nothing but that's much more, simple than it really is. It is a book of trauma, and the diagnostic categories are simply a way in which our clients, our patients, are expressing their trauma, be it a mood disorder, or be it an anxiety disorder, and an explosive anger disorder, or whatever, personality disorder even.
Right. That
underneath all of it really is trauma, and often developmental trauma, starting very, very early.
So it's really interesting because, as you know, I'm also a professor at Cal State Fullerton grad school, and my students in their practicum course have to put a tentative diagnosis and pros and cons of why that's the diagnosis. And they come in, they present these cases with trauma after trauma after trauma after trauma, as kind of what we expect. And then they put in all of these diagnoses like major depression or generalized anxiety. And I'm like, or PTSD, Let's get, but it's interesting because they have to put the pros and cons. And if you look at the criteria of each diagnosis, you can see why people are putting bipolar, major depression, whatever. You can understand why they would be doing it, but that does seem to be missing the point, doesn't it?
Yeah, it's an interesting dilemma, and I think there's a paradigm shift that may be happening, at least in parts of the mental health profession, that they're beginning to look at it and realize, wait a minute, I actually had a referral from an ER doctor recently, who was educated enough that when the patient came in and they were saying it was acute psychotic episode, it looked that way, but the ER doc was bright enough to say, but it also seems like they're in an active flashback phenomena. And flashbacks, they can see things, they can hear things, and you go in from the surface interpretation, seeing things as visual hallucinations, hearing things like explosions or yelling in the distance are auditory hallucinations, when the person going through it may be going through a wartime experience or reliving it, and what they hear and see, they're actually hearing and seeing the experience they went through in a traumatic situation. And I'm sorry, that isn't what is meant by auditory or visual hallucinations from a complex PTSD position. The other thing is, that's difficult, is that complex PTSD is not a category that is diagnosed in our DSM. But the ICD-11 in 2022 has included it. So I hope that people will go to ICD, International Classification of Diseases, 11th edition, and look up how that organization has placed complex PTSD as a diagnostic criteria separate from post-traumatic stress disorder.
Curt, I have a question for you.
Yeah.
And I truly don't know the answer to this, so I'm really curious. And if there is an answer, as part of that differential diagnosis between psychosis and flashback, is there the length of time someone may be in the episode, is that different for someone who has a psychotic break as opposed to a flashback?
Yeah, in my experience, flashback phenomena is much shorter lived than an ongoing psychotic episode. Mm-hmm. A patient within the last year was a woman that was spent 2 weeks in a psychiatric facility, locked down, because she had a, quote, acute psychotic disorder, paranoid and all of this. And what really happened as she got to me in an outpatient setting was I began to realize that she had been triggered by something in her environment. She was a mature woman, and she got triggered by something in her environment. And part of it actually had to do with the age of her children.
Oh, interesting. Yeah, that happens, doesn't it?
Oh, yeah. And she began to get in touch with an early sexual abuse trauma, and it came out with feelings in her body, with thoughts about the unsafety of her children, lack of safety, when her husband was absolutely not a pedophile.
Right.
But, all of this and the paranoia, are my kids safe, this sort of thing. And we worked on it, and all of a sudden, I remember the day she looked at me and she says, "I wasn't crazy."
No, not even a little bit.
I said, "Not even a little bit. I spent 2 weeks in a psych facility." Now, here's the deal. After the first 24 hours of her flashback episode, she spent the rest of the time going around and working with people in far worse states than her. Mm-hmm. She listened and she talked to them. In her words, she would minister to them, And
so she didn't stay in the flashback for 2 weeks.
No, not at all. But of course, because of that experience, they kept her in and had to keep her in. And when she was, ironically, it's when she was helping all these other people, the staff, the medical staff around her, she's trying, she's pretending so she can be released.
Right. It's wonderful how we view things through certain filters. You had said, and I've certainly seen this, people who, again, the assumption of the diagnosis, and so they're medicated for that diagnosis. And I have had quite a few people come in with bipolar diagnosis and medicated, and it doesn't seem to really be helping. And as my joke is, I can cure bipolar because it was never bipolar in the first place. It was complex PTSD. And as they work through the trauma, they heal from the trauma, oh my God, they don't have bipolar anymore.
That's right. Because when you desensitize and reprocess the trauma, the patient doesn't have to express it in whatever way that it was expressed before, mm-hmm. because the memory, the traumatic memory, has been desensitized. Now, I'm not saying, and I know you're not saying, that there aren't people who have bipolar 1 and bipolar 2. They exist. But even with the real diagnoses of bipolar or acute psychosis or whatever, mm-hmm. Our colleague in Northern Ireland, Paul Miller, a psychiatrist, wrote that whole book on EMDR with schizophrenia and other psychotic disorders. Mm-hmm. They could have bipolar, but mm-hmm. it's interesting how the cycles often become less prominent when you deal with the trauma of even having the diagnoses.
Right. Yeah. Paul Miller has a great, in his book and some of his workshops, he's got some great stories of how the symptomology that his patients come in with, because they're schizophrenic, because they're psychotic. And after he does the work with them, they're still schizophrenic or psychotic, but they are functioning at a much better level, and those symptoms are not so big anymore. I had a consultee that I worked with who worked in downtown LA, which is, a great place for a lot of homeless, mentally ill people. And as she started doing EMDR with them, they went from being hospitalized once a quarter to once a year.
Oh, yeah. And in a life, that can make a great deal of difference.
Right?
In terms of quality of life.
Absolutely.
So when it comes to, legitimate diagnoses of some of those hardcore diagnostic categories, like bipolar, schizophrenia, etc., those are things that EMDR isn't going to get rid of. But as I said, the intensity of the symptoms, the frequency of it can be decreased. But I'm talking about, as you are, those cases where people come in and mental health professionals have done that surface look and done the checkbox on the DSM, and they say, oh, you're this, this, and this. And they begin to give them medication that, if they were, that diagnosis should work.
Right.
And, of course, what we often find in complex PTSD is people have been on all sorts of medications for years, and none of them have really been very effective. When we talk about dissociative identity disorders, dissociative states, which is an example of one of the most complex PTSD expressions, these people have been in treatment for years, and they begin multiple diagnoses. When you see someone come in with bipolar, with schizoaffective, with paranoid schizophrenic, with blah, 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 then a red flag should go up in your head. Wait a minute. Maybe we're looking at one thing that's being expressed through this patient through mood issues, and that's complex PTSD.
And have you seen, I know I've seen this, that with some medication that should help if they have this diagnosis, but that they get worse on the meds rather than better, because it's, right?
Oh, yeah.
They don't have the diagnosis.
Yeah, that's why when in situations where the client has DID, the antipsychotics are not helpful at all. Well, first of all, it's not psychosis that they're experiencing; it's a dissociative state, But severe dissociation is one of the signs, of course, of you often find in complex PTSD, and the medication has not been effective. So it's that whole thing of, I hope, and as I said, the ER doc even recognized that what he was seeing although on a surface level looked like an acute psychotic episode. At first, of course, they thought it was drug-induced, but tox screen was completely clear.
Right.
And that makes sense. When you're in ER and a person's acting weird, you're wondering, okay, are they on a drug, illegal drug, or even a legal drug they've taken too much of?
Mm-hmm.
And they do the tox screens, and it comes back clear. And I say, okay, well, what's happened? And hopefully this medical personnel will, more of them will begin to look at their patients coming in those kinds of states and say, okay, what role is trauma playing in this? Right.
And, depending on where they are, how much do they know their history? An ER doc may not have history.
That's right.
But, it's helping people to make that differential diagnosis. You've talked about with folks who have DID, for example, are the voices in their head or the voices outside their head coming into them, right? And that can be a differential diagnosis between someone who has DID and someone who is psychotic.
Yes, it's sort of like you got to ask the next question. When in a psychiatric or mental status exam, you ask, do you hear voices? And, I've had many of my patients, of course, with dissociative identity disorder say yes. And unknowingly, that gets labeled auditory hallucinations. And a simple question of, well, do you hear the voices? Now, this isn't always true, but in general, are the voices from outside or inside? Because oftentimes in schizophrenia, it's what they call MADE, M-A-D-E, quote unquote, made symptoms, like they're being forced, they're being made to do things. Mm. The lack of volition you see in Schneiderian first-rank symptoms of schizophrenia. Auditory hallucination, voices telling them to do bad things, or having them fantasize or see bad things. They look at someone and think about doing something horrible to them, and they see they didn't have control of it, and so it's called MADE symptoms. And of course, the voices. Yeah, I do. Well, hopefully now people begin to ask, do you hear them inside or outside? Because often in dissociative identity disorders, they hear voices, but it's internal dialogue. It's voices of one alter talking to another alter, or what they feel is background noise, a conversation going on in your head that bothers them. But it's really alters that are commenting on things. And that's not psychosis. That's part of the dissociative identity disorder. And I also love the fact that, many of these patients with complex PTSD were the ones that people like Pierre Genet back in the early days were actually working with. And I remember years ago, Colin Ross did a presentation, and he listed the different diagnostic or symptoms of what he said was dissociative identity disorder. And it hit everything to a T. And then he flips the next slide, and it's Emil Kraepelin, one of the early researchers back in the 1800s on schizophrenia. And those were the diagnoses he was using for schizophrenia.
Right.
He says, wouldn't it be interesting if we look back and see that perhaps some of those characteristics were dissociative issues, not schizophrenic issues?
So I want you all to think about this, right? Don't assume the diagnosis that your client comes in with is the correct diagnosis, one. Two, well, and also, think about your doc that you were just talking about. Oftentimes these diagnoses are given really quickly. Yeah. They don't necessarily have had the time to really sit with them and figure it out. So don't assume that that's the correct diagnosis. It might be, and it might not be. But when you're looking at treatment planning for these folks, whether it is the real diagnosis or not, please target their trauma history.
Yeah.
Whether it's their trauma history, developmental, the horrible things that happened to them growing up, or as Curt was saying, the trauma of having a severe mental illness. Target that. All of these are wonderful things to target. And then after all that's done, then see what's left. Are they like the woman you were talking about, Curt? Are they actually just fine?
Right.
Right? Or are they maybe much more functioning people who have severe mental illness?
Michelle, I always go back to what you talk about when you talk about working with chronic pain and how you start working with their trauma, like family trauma. And they'll say, when am I going to, after a while, they say, well, when am I going to work on my pain? And you ask them, well, how's your pain level now? Mm-hmm. And they come in, when they came in, it may have been at a 10. And I said, oh, it's only about a 5. Mm-hmm. And you tell them, we have been working on your pain.
All right.
Because we've been working on the trauma.
Right. Absolutely. So everybody, thank you for all that you do. Take all of that we've been talking about today as just ideas and thoughts and again, part of the paradigm shift that we're always in of looking at things differently. Be curious if your folks really are severely mentally ill, and they might be, or is it complex PTSD?
As Ted Laszlo says, when he read a billboard by Walt Whitman, be curious, not judgmental.
Oh, I love that. I love that. Thank you all for hanging out with us. We do appreciate each and every one of you.
All right. Bye-bye. Until next time.
Bye.